So I think some of the challenges with left main disease are, if you look at anatomic evaluation for left main disease, there is a challenge because of vessel overlap. So sometimes even with the best possible extreme views, you may not be able to open up those bifurcation and see those ostia of the LAD and SHRC clearly. Of course, there is challenges with calcification. If you're doing intercoronary imaging, there is also challenges with the catheter being not coaxial, and that can cause problems with the evaluation of left main disease. When you think about physiology for left main disease, there is also a number of challenges, typically because left main lesions tends to be short, but at the same time it's supplying a large territory of myocardium. So if you look at non-hyperemic pressure ratios, I mean, this is exactly the type of lesions where the separation coefficient kicks in, and you can have falsely negative non-hyperemic pressure ratios. So what are the limitations of angiography for left main disease? A number of studies have looked at this. This is one of the studies looking at a 50% threshold for left main disease. And if you use that angiography alone, in 6% of the cases, we had angiographic stenosis, QCA stenosis of 50% or greater. There is overestimation of physiological significance of the left main lesion. More importantly, if you only use that 50% or greater threshold, you're going to miss 23% of patients who can have positive FFR less than 0.8. And as such, the accuracy of QCA determined diameter stenosis greater than 50% to predict physiologically significant stenosis is only around 71%. There is also a lot of inter-observer variability of left main stenosis determination on angiography. So here in this study, you can see that the agreement by two reviewers was only 74%. And of course, I mean, there is a lot of lesions which are overcalled or undercalled, and even between the two reviewers, there is a significant disagreement as to which lesions are significant. What about going beyond angiography? What about IVUS for left main disease? And this is data from Gary Mint's work. Here, in 25% of patients, the left main MLA differed by 1 millimeter square when imaged from a pullback beginning in the LAD versus pullback beginning in the circumflex. So this is very important data, right? Because, I mean, as we were talking about coaxiality of our IVUS imaging catheter, this is important because 1 millimeter may mean a difference between whether you're going to treat it versus not treat it. And as we were taught, the smallest MLA is always the most accurate if you were to do these kind of pullbacks. The other limitations of IVUS in left main disease is what is the cutoff we use? I mean, typically I use a threshold of less than 6 millimeters for considering something to be significant for left main stenosis. But of course, there is variability in cutoff values depending on whether you're looking at a North American population versus an Asian cohort. So here, as you can see from these two studies, these are looking at cutoff value for intravascular imaging to predict an FFR threshold of 0.75. So if you're looking on the panel on the left, it's a North American study showing a threshold of 5.9 millimeters square, which we commonly use. But in Asian patients, the threshold is, because the arteries are smaller, the threshold is much lower, 4.1 millimeters square. Again, so as can be seen here, if you're using an absolute MLA cutoffs, we have to be a bit careful because this does not take into consideration the vessel size. So the same absolute threshold can be adequate for a smaller patient, and it may be too small for a patient who has large coronary arteries. Moving forward from intravascular imaging, let's talk about challenges with the FFR measurements of the left main. So these are some of the work that Bill Ferron and his group did. So I kind of graphically depicted them. So here you see a left main lesion and an LAD lesion. So the challenges with assessing physiological significance of a left main lesion is, first of all, let's talk about the impact of tandem lesion. So if you have a lesion like this, and if you were to measure FFR distally beyond all of these lesions, the FFR may be 0.66. And if you do a pullback here, this may be 0.82. I have seen many people erroneously conclude that the left main is not significant because they did a pullback here and this FFR just distal to the left main is not significant. We have to be very careful with this because a number of in vitro and also human studies have clearly shown that the impact of these tandem lesions is kind of difficult to predict. The only way to ensure that you're getting accurate measurement is to treat this most severe or the most most distal lesion first and remeasure an FFR. For example, here, graphically putting in a stent here and you remeasure it. And what this does is it actually increases the flow across this lesion and can unmask a falsely negative FFR. So here you can see that the FFR now is 0.79 because you're increasing the flow in the LAD and unmasking the severity of the left main lesion. The other problem with assessing physiological significance of a left main lesion is downstream lesion. So let's talk about a left main lesion here. This is an isolated left main with no significant stenosis of LAD and circ. And if you assume that this FFR, when you measure it through the circumflex, was 0.77, let's see what happens when there is a concomitant lesion in the LAD. So if you have a severe lesion in the LAD, we talked about the FFR there being 0.66, and now if you measure the same FFR in the circumflex from the previous 0.79, now you see that the circumflex FFR is 0.81. So in other words, this is an apparent FFR. This is not the true FFR, but this is getting influenced by significant stenosis in the LAD. And so what's been shown from a number of studies are this falsely elevated negative FFR of left main can occur in 1 in 10 patients. And it's more common if the branch vessel has significant stenosis. So in other words, this is only seen at the extreme of FFR. So if the combined FFR in the LAD is less than or equal to 0.5, then you can have a falsely negative FFR when you FFR through the circumflex. It's also seen if the branch vessel stenosis is proximal, so in other words, it's supplying a large territory, and the impact is similar whether the downstream stenosis is in the LAD or in the circumflex. But just to simplify all of these, I mean, it's many a times when you're doing these measurements, you don't want to be thinking about, okay, is there a downstream lesion? How severe is it? What is the location of it? The simple algorithm to consider is measure FFR in the least diseased of the two branches, preferably the LAD because it's the larger artery and supplies more territory. If the FFR is less than 0.8, consider revascularization. If it is greater than 0.85, even if there are tandem lesions, you can be assured that the true FFR will be greater than 0.8 in most of the patients, so you can defer revascularization. If it is between 0.8 and 0.85, then you have to think about tandem lesions, downstream lesions. These are the cases also consider using IVUS or OCT to make that decision. So forgetting all that I said in the prior two slides, I think this simplifies it. Less than 0.8, revascularize. Greater than 0.85, defer revascularization. For something in between, use IVUS or OCT. Okay, so let's now move to non-hyperemic pressure ratios. Interestingly, I mean, I must say in most practices in the US, there is a rapid shift towards using non-hyperemic pressure ratios. And I've had problems with this, as we'll talk about it, because there are limitations of just using non-hyperemic pressure ratios. I mean, it's great, you don't have to use adenosine, but there are limitations. And the limitation is kind of summarized in this slide. So if you have a tight, short, proximal lesion supplying a large territory, these are the patients where the non-hyperemic pressure ratios can be falsely negative. And these are the ones where there is a large increase at hyperemia, and so you may unmask a significant gradient with hyperemia rather than at rest. So how does a non-hyperemic pressure ratio do for left main stenosis? There is a study which was recently published called the iLitro-EPIC 7 study looking at FFR and IFR for patients with left main disease. Important to recognize that the concordance with FFR is only 80% if you use IFR. More concerning is the fact that if you use a MLA cutoff of less than 6, FFR was negative in 35% of patients, but if you look at the non-hyperemic pressure ratio, nearly half of those lesions were negative on an IFR. So just to summarize, in terms of non-hyperemic pressure ratio, IFR, DFR, RFR, there is only modest concordance between FFR and non-hyperemic pressure ratios. Given that the lesions are typically proximal and supplies large myocardium, it's a setup for falsely negative non-hyperemic pressure ratio, the concept of separation coefficients. In those with negative IFR, 46% had an MLA less than 6. I mean, I must say that it's nothing to do with just left main disease alone. If you have a proximal stenosis and non-hyperemic pressure ratio is negative, I typically follow that with at least a contrast FFR. I mean, you have the wire there. It's easy to administer contrast. At least do a contrast FFR, adenosine FFR. Okay, so I think in the interest of time, there are a number of data, all observational studies looking at can you defer revascularization either based on FFR or based on MLA thresholds. And there have been data suggesting that there is safety of doing such an approach. Finally, I mean, all we talked about so far is diagnosis of left main severity. What about imaging guidance for left main PCI? Again, this is data based on multiple observational studies, clear decrease in mortality, MACE, and thrombosis, TLR. This is observational. Of course, Ziad and team are doing a large randomized trial, not necessarily restricted in left main disease patients, but looking at importance of OCT for post-procedural optimization for our patients. Of course, if you're using imaging to optimize left main PCI, again, I think we have to be careful. Just as we talked about MLA thresholds, there is MSA criteria, minimal stent area criteria, whether it's a small Asian patients or a large Caucasian patients. And finally, I want to leave everybody with this. This is the pyramid of diagnostic accuracy. So if you rely on coronary angiography alone to dictate whether a lesion is physiologically significant, the accuracy is only 65%. And if you use resting physiology, the accuracy increases by 80%. The contrast FFR is 85% and FFR is 95%. So just to summarize, FFR and physiology imaging provide complementary information for evaluation of left main disease. So if you're looking for diagnosis, FFR, beware of technical challenges, tandem lesions, downstream stenosis, non-hyperemic pressure ratio, there is reduced accuracy as we discussed. If you're doing intervention, in my books, it's absolutely necessary to do 100% imaging guidance, especially for left main disease. Helps with plaque characterization, stent sizing complications, and also you can evaluate physiological significance of circ ostium. Thank you for your attention.